Welcome to Bullet Point Nursing. My name is Dr. Goldstein. And whether you're here as a nursing student, whether you're preparing for the NCLEX or you're preparing for nurse practitioner school, I hope that this series will help you. In this roughly 8-hour lecture series, we're going to cover almost the entire nursing pharmacology curriculum. You can download the notes that we're using in this lecture and you can follow along with it. It's highly recommended to do that and to also write comments in the notes as we go along on all the extra information I'll be giving that's not in the slides. This is the first lecture in this series, so let's go ahead and begin talking about the fundamentals of pharmacology. First, we begin with talking about the various routes that we have available to administer medication to our patient. The routes are broken up into parenteral routes and enteral routes. Enteral means through the GI system. So for enteral routes, we have PO, which is oral. We have NG and OG, which are tubes that are placed down that go into the stomach. And we have ODT, which is an oral disintegrating tablet, where the medication basically dissolves into our saliva and we swallow it that way. The thing that all of these routes have in common is that the patient gets the medication through the GI tract. It goes into the stomach, it gets absorbed through our GI system. Then we have parenteral routes. Parenteral routes go around the GI system, and it includes all other routes that we have available. The fastest route of medication administration is IV, intravenous, which is one of the most common methods used in the hospital setting. Obviously, generally speaking, the most common route of medication administration, all included, is going to be PO or oral. Other parenteral routes that we have are subcutaneous, intramuscular, and intraosseous. We have a few other routes as well, which is buccal, placing it in the cheek, sublingual, which is under the tongue, rectal, and vaginal. And then we have a few more routes to review. First, we have transdermal. Transdermal is not the same as topical. Transdermal is where the medication is absorbed into the skin. It goes into the subcutaneous tissue and into the bloodstream, and it is absorbed systemically. Inhalation, where we breathe the medication in. Topical, where we put the medication on the skin, but it doesn't get systemically absorbed. It just affects the local area, the local tissue. Intranasal, where we administer it into the nose, and that can be both systemic or it could be localized. An example would be if I give a patient Afrin. Afrin is the brand name for oxymetazoline. That drug is used for allergies, and that only has a localized reaction. However, if I give you Versed or naloxone, Narcan, if I give you either of those intranasally, which they are both available, those would have systemic effects. Ophthalmic, which is in the eyes, otic, which is in the ears, and then intradermal, really the only time we see that is a TB skin test. Two different other concepts to understand with giving medications. IV push is where we push the medication in versus IV infusion, which is also known as an IV drip. Parenteral routes are almost always going to be quicker than an enteral route because it doesn't have to go fully through the GI system. Intraosseous is unique because intraosseous is the only route that's available that is 100% interchangeable with another route, and in this case, IV. There's no other two routes that no matter what the drug is labeled for, any drug labeled for IV can go into the intraosseous route. No drug is really going to be labeled IO. It's understood that anything that is safe to go IV is able to go into the intraosseous route. Next, I also want to mention that most routes are able to have systemic effects. Like we talked about, transdermal, PO, IV, all of these are able to have systemic effects. However, generally speaking, we would rather have a targeted, narrow, localized effect if at all possible. And this occurs in many different ways. For example, if a patient needs a steroid, I would rather give them a topical steroid than an oral steroid. They might both get the job done, but the topical is only going to target the exact area that the patient needs targeted, versus oral is going to affect their entire body, and we're going to get the bad side effects that go along with that. Next, we want to know what extravasation, also known as IV infiltration, is. And this is where we give a patient, we start an IV on them, and IV literally means intravenous, into the vein. And that's where I want my medication to go. However, if the IV is bad or becomes bad, that vein is no longer where the medication's going. It's actually leaking into the local tissue around the IV site. And that's a problem, and that's called extravasation or infiltration. And depending what the medication is, it may be a problem, it may not. If all you're giving is normal saline and you catch it pretty quickly, then all they got is a little bit of essentially salt water that's leaking into the local tissue. They'll have a little bit of a swelling or a black and blue mark, it'll go away. If you have something else like potassium, like glucose, like norepinephrine that leaks into the local tissue, those can be really big problems, and we're going to learn about all of that. A CVL, or a central venous line, is another method of giving a patient a medication. It's the same as an IV because it is literally IV, it's still into the vein. However, a central venous line has the big advantage that the medication itself has a lower chance of infiltrating, which if it's one of those toxic medications, that's a really big plus. Let's go through a whole ton of terminology that we're going to have to use as we learn all about pharm over the next few hours. First of all, drug and medication are interchangeable terms. One of them has a little bit of a negative connotation. However, in healthcare purposes, we use them interchangeably. A prescription refers to any provider order, not just a medication. For example, I'm a nurse practitioner. I can prescribe someone to be on bed rest. Even though that's not a medication, that's still a prescription because it is a provider order. Pharmacotherapeutics refers to using medications for improving health. This is important to understand because throughout this lecture, we're also going to talk a lot about non-pharmacological interventions. For example, if someone has insomnia, if they're not sleeping well, we are able to do non-pharmacological interventions. And we're going to learn about that. Turn down the lights, have the environment be a little cooler. Those are all non-pharmacological interventions that we're going to use for our patients. But that's in contrast to pharmacotherapeutics, which is most of what we're talking about, obviously, in pharmacology. Pharmacokinetics is how medications move through the body. Pharmacodynamics is a way the drug changes the body. So the mechanism of action is sort of a combination between these two, but it's more so pharmacodynamics. It's more so what does the drug do to the body to have the desired effect, which is the next item on our bullet point, mechanism of action, or MOA. We're going to learn this for every single drug. And some of them, actually, we don't know the mechanism of action. We just know it works. We don't know why or how, but most of the time we do know it, and we are absolutely going to learn that, because if you understand that really well, then you'll understand other aspects of the drug. For example, what is it used for and what are its side effects? Almost every drug has a trade or brand name. Some examples would be Tylenol or Advil or Humira. Those are all trade or brand names. On the flip side, we have generic names. These are the actual drug names that we use in healthcare. Some examples would be acetaminophen, ibuprofen, ketorolac, and things like that. Please note that while most drugs do have both a generic name and a trade or brand name, NCLEX and most educational institutions are only going to be using the generic name for testing. So you must know the generic name. However, your job as a nurse or as a nurse practitioner is going to be to talk to patients. And patients don't always know the generic name. They're much more familiar with Humira than they are with adalimumab. And it's going to be your job to know both of them. Because when you're talking to the patient-facing side of healthcare, you want to know those brand names because that's what the patient knows. Versus in our EMR systems, in our tests, in our schooling, we have to know the generic names. A combination drug is a single pillar solution that contains multiple medications. And you've likely seen this. We have this for, let's say, blood pressure, where you have a lisinopril and a hydrochlorothiazide together in one little pill, just to make things simpler so the patient doesn't have to take multiple pills. Most of the drugs that we're going to learn about in pharmacology are put into a drug class. For example, we have NSAIDs, non-steroidal anti-inflammatories, or one you also may be familiar with, beta blockers, or the proper name is beta adrenergic receptor antagonist. In any case, we learn drugs by drug class. And the reason for this is because I can learn about the drug class, let's say beta blockers, and I can learn all about it. And then I know all about propranolol and metoprolol and labetalol and esmolol because I learned about the drug class. I now actually learned about 5 or 10 different drugs, in that case, more than 10. However, we have to understand that almost all of the drugs within a class are going to be the same for almost all intents and purposes. However, they are sometimes going to have specific differences. To stick with our beta blocker use, we have carvedilol. That is a beta blocker. It works the same. It's used for almost the same things. However, that one is preferred for heart failure, as opposed to propranolol, which is preferred for something like anxiety, as opposed to esmolol, which is preferred for something like a AAA. So we want to understand that all the drugs in a class are going to work almost the same exact way. However, they may have slight differences between them. They may all be, for example, a statin medication, which we're going to learn about in a little while, are all used for cholesterol, and they're used relatively interchangeably. But of the 6 or so statins that we have, some of them are a little bit stronger than others, so they do have that slight differences between them. That's pretty common. For there to be a big difference between 2 drugs within a single class is pretty uncommon. Over-the-counter, or OTC, is for sure a term you're familiar with. And this is drugs that are FDA approved, and that means that they are safe for the general public to consume without a physician or healthcare provider as the middleman. However, keep in mind, even though a medication is over the counter, it is still treated as a medication. So when you're taking a patient's history, you need to document if they're taking any over-the-counter medications, and that needs to be in their chart. Same thing if you are a nurse or a nurse practitioner working in a hospital setting, you need to understand that even those things that out on the street you could just hand out like anything, like a Tylenol or an Advil, in the hospital setting, it does need a prescription because it is a medication. Onset is one of the most important things to know about a drug because we want to know how quickly it takes effect. If I give you an acetaminophen for your headache, I want to be able to tell you this is going to have its effect within 30 minutes or so. I want to be able to give you that time window that you'll know you are going to get relief. If I'm giving you Zoloft for your depression, I want to be able to tell you this is going to help make you better within, let's say, 4 weeks. I need to give you that time frame, and that's what onset is. Duration is how long a medication lasts. And this is pretty simple to understand because it's usually how often we dose a drug. If a drug lasts for 12 hours, we're usually going to give it every 12 hours and things like that. But duration is how long the medication's effects last. It may last in our system longer, but how long its effects last is its duration. Indications are simply what do we use this drug for? To go back to our example of beta blockers, well, we actually use that for a lot. We use it for heart failure, we use it for angina, we use it for anxiety, we use it for a lot of different things. But an indication is what the drug is used for. First pass effect is probably something you don't need to know in practice, but it is something that you have to know as part of your education because it is required knowledge. And what is it? It's a reduction in the medication by the liver, and it only applies to medications that go through the GI system. Blood-brain barrier is a barrier that the body has that protects all the blood that comes up into our brain, and it protects it from harmful substances. And normally this is a really good thing. If some pathogen or something else makes its way into our bloodstream, if it's with this barrier in place, we can at least protect the rest of the brain. However, because of this, we also have to understand that some medications that we want to go up there and affect the brain are not able to. And again, this is something that we deal more so with in the pharmaceutical industry where they're creating these drugs that sometimes they have to figure out how can we get this drug to have its effect because this is a hindrance. Excretion is how a drug is eliminated from the body. Most important thing to know here is that the primary organ of elimination of excretion for most medications are the kidneys, and that's critically important to know because almost every prescription medication out there is going to have a dose adjustment if the patient's kidneys are not working. Because remember, if the kidneys are not working, they can't get rid of it the way it was intended, so we have to adjust the medication dose, or else with the body not getting rid of it and us keep taking more and more as if it was, we can build up to a toxic level. Next, we have metabolism. Metabolism, also known as biosynthesis, is the way that the drug is processed through the body, and that is done primarily by the liver. Again, important to know, because if the liver is not functioning properly, if they have cirrhosis, if they have hepatitis, if the liver is not functioning properly, we have to understand that that may alter the effects of the medication for better or for worse. Half-life is how long it takes until the medication level drops by half. So for example, if I take an aspirin, then my aspirin level in my bloodstream, once it's been absorbed, my aspirin level in my bloodstream is going to go up to this number. Half-life is how long does it take until that level drops in half. So if let's say my headache from my aspirin, it goes away when the aspirin level's at 100, how long until the aspirin level drops to 50? And that's pretty closely tied to duration. Once the medication level drops significantly, that's usually when the medication effects wear off, which is what the duration is. A loading dose is where we give a patient a large dose of a medication to quickly bring the medication level in our body up to the desired amount, because we want to quickly have it kick in and start working. There are a few key medications where this is applicable. I wouldn't expect that you'd have to memorize that. A common example would be azithromycin or a Z-Pak, where we take 2 pills on day 1, and then we take 1 pill a day for the next 4 days. That's an example of getting a loading dose, where we're quickly bringing the medication level up to where we want it to be, and then we allow it to just maintain at a maintenance dose, which is the next item, and that's where the dose is given to just keep it at whatever we built it up to. Keep in mind, most drugs do not deal with a loading dose. Most of the time, the medication is just to be a consistent dose, and that's what's been formulated to get us the proper results. Potency is how strong is your medication. This doesn't mean how good it is or anything else. This just means how strong it is. Efficacy means how effective it is. Keep in mind, these are 2 different terms. I want to take the most effective medication. Doesn't mean I want to take the most potent. I just want the one that's going to help me the most. If there's something stronger out there, that doesn't necessarily mean that it's more effective. An agonist is a medication that stimulates a specific receptor or a substance. And we deal with this all the time. And the contrasting side of that is an antagonist. That's where a medication inhibits the effects of a receptor. And I'll give you a few classic examples. Beta blockers. We know them as beta blockers, and once we get to that section, we're going to learn the proper name. But those are beta-1 adrenergic antagonists. An antagonist is a beta blocker. Know and recognize those 2 terms. If a drug class says it's a blocker, an antagonist, or an inhibitor, those are all the same thing. Another common one that you're probably familiar with are antihistamines. Again, once we get to that section, we're going to learn that antihistamines are actually histamine 1 receptor antagonists. Again, that word antagonist, they block the release of histamine. So again, an antagonist means that it blocks what a cell is meant to do. An agonist means that it promotes what a cell is supposed to do. If I give you an opioid, it's going to activate opioid receptors. If I give you an opioid antagonist, which is Narcan, I'm going to block or antagonize opioid receptors. We already discussed that indications are what a drug is used for. Off-label use is when a medication is used for an effect other than what it's FDA approved for. So every single drug, at least in the United States, in order to be available for sale, it has to be FDA approved for something. But once it's FDA approved for something, and now it's stocked on the shelf, providers can prescribe it essentially for anything they want that they feel is reasonable and that they can justify as medically appropriate. If you're using it for something other than what it is intended to be used for, that is called an off-label use. Hey, since you're still watching and enjoying this lecture, please go ahead and hit the subscribe button and subscribe to our channel. This content is all offered as a free resource for nurses, nursing students, and nurse practitioner students. This channel is supported simply by you pressing the subscribe button and enjoying it. Let's go ahead and continue. Taper is where we slowly decrease a patient's medication dose. Titrate is the opposite. It's where we slowly increase a patient's medication dose. And throughout pharmacology, we're going to learn a lot of different drugs that have to be titrated up and tapered down, meaning they have to be slowly increased and stepped down when we're ending it. Probably the most famous example of a drug that needs to be tapered down would be steroids. Let's go through a few allergy terms that you're probably familiar with, but we should review anyways. The first is NKDA, or no known drug allergies. If I see this on a patient's chart, I know that this chart says this patient is not allergic to sulfa, they're not allergic to Tylenol, they're not allergic to morphine, they're not allergic to any drug. It does not tell me if they're allergic to shellfish, or latex, or strawberries, or their parents, or anything else. I have no idea. I do know they're not allergic to drugs. If it says no known allergies, now I know they're not allergic to anything. They're not allergic to drugs, they're not allergic to people, they're not allergic to plants, they're not allergic to anything. Refractory is a term that you may see, especially at the nurse practitioner level, and it means when a patient does not respond to a medication or a treatment. And how would I use that in a sentence? So for example, I would say that my patient is hypotensive, refractory to 2 liters of fluid. What does that mean? That means they have a low blood pressure and it hasn't responded to 2 liters of fluid that I've already given them. Generally, when we see that, that's a bad thing. That means that my patient is not responding to the treatment that I gave them. A black box warning exists on a good portion of drugs, and it's the highest level alert that is placed on a medication for the provider or the prescriber to consider when giving this medication. It's saying, hey, this medication, let's say an example, is hepatotoxic. It does not play well with the liver. So a black box warning that this medication has hepatotoxicity makes me alert that, hey, if there's any problem whatsoever with this patient's liver, I maybe should not give this medication, or I should at least consider very carefully what I'm doing. Not only that, if it has that black box warning, I should probably also make sure I actually check the liver to make sure that it's fine before I go ahead and just assume that it's okay. A consideration is an alert to consider the risk versus benefit of a medication. And again, it's the same as a black box warning. However, a consideration is a little bit of a lower level. Black box warning is more in your face. Be very careful with what you're doing. A contraindication is a do not proceed. Contraindication example, there's lots of them. I would not give a beta blocker to a patient that has a heart rate of 40. It's contraindicated because if the patient's heart rate is already 40, this beta blocker is going to lower it even further. And unless I'm trying to kill them, that's not going to be an appropriate medically sound course of treatment. MDV, or multi-dose vial, is something that you probably see in practice, even if you're just starting off in school. It's where a container of medication has multiple doses in it. When we get amoxicillin, when we get a strep throat and we get amoxicillin from the pharmacy, if it comes in a solution like when we're kids, that is technically a multi-dose vial. It's not a vial, it's a bottle, but it's the same concept. It has multiple doses in it. In the hospital setting, please note, the vast majority of all medications are a single dose vial, and we're going to mention that again in just a little bit. But the point is, when you see MDV, do not give the patient the entire vial, please, again, unless you're trying to kill them. If it says multi-dose vial, please be very cautious to know that that vial has multiple doses in it, and you're not going to be giving all of it to one patient. Minimum effective concentration is the lowest concentration where the medication is effective. This is referring to the concentration of the medication in our bloodstream. For example, if I take acetaminophen, Tylenol, the lowest concentration where my headache starts to get better, when the Tylenol level gets to a certain number in my bloodstream, and now my headache starts to go away, that's the minimum effective concentration. That also coincides with the onset of action that we talked about earlier. The onset of when a medication starts to do its job is the same as the minimum effective concentration. The minimum concentration of the medication when it starts to become effective, when it starts to make my headache better. Toxic concentration is probably self-explanatory. It's where the medication becomes toxic and harmful. Therapeutic range, again, probably self-explanatory, is the range between those two numbers, between where it starts to work and where it starts to hurt you. Everything in between is the therapeutic range. Next, we're going to talk about side effects and adverse effects. Side effects is any unintended reaction to a medication. This could be good, this could be bad. If you take Zofran, a very common nausea medicine, it is known that it causes headaches. That's a side effect. It happens, I don't like it, but it's the price I pay to take this medication to get rid of my nausea. Some side effects are good. It's been all over the news for the last 6 months. We're here in the middle of 2023, and we've been talking about Ozempic, a weight loss and diabetes drug. That drug has been around for many years, and it's been known to treat diabetes, and it's been used to treat diabetes, but it has a side effect of causing weight loss. In this case, a lot of people like that side effect, and now we're actually starting to see it get used more and more just for that side effect. Keep in mind, Viagra, when that drug first came out, it was nitro and it was used for something else, and we found that it had a side effect of fixing erectile dysfunction, and we developed it to be used specifically for that, but it began as a side effect. A side effect can be a good thing or a bad thing, depends what it is. An adverse effect is an undesirable side effect. It's something that we do not want, that is, generally speaking, a pretty big deal. An adverse effect, for example, of lisinopril, that's a very common medication, and that causes a cough, okay? Or it can cause angioedema. A minor cough would probably be considered a side effect. Angioedema or facial swelling from taking it, that's a pretty big deal. That's definitely undesirable. That's an adverse effect. I don't think you would ever have to know which one's a side effect, which one's an adverse effect. Very often they're used not interchangeably, but very similarly throughout this course. We're going to use them. We're going to lump them all together. Tolerance is when a set dose has decreased the efficacy due to previous exposures. Most of you are probably familiar with this when it comes to opioids. We know that the more a patient takes, let's say morphine or heroin, those are both opioids, the more a patient takes it, the more it's going to take for them to feel that same effect. Same thing, if my kids drive me crazy all the time, I get used to that. And then it takes them being even more crawling up the wall for them to get me that same level of crazy. A CAM, or complementary and alternative medication, are something that we're going to ask every single patient about to know what they're taking. Because today there are, I don't even know the number, for sure dozens, probably well over 100 different CAMs on the market that patients take for healthcare. These are not FDA approved for anything. Some of them may be FDA cleared as being safe for human consumption. Do keep that in mind. A CAM is not an FDA approved medication. It might be FDA cleared as being safe for human consumption. Some examples of these are listed here, and some of these are very commonly used. Echinacea for cold and flu, chamomile for anxiety and insomnia, ginkgo biloba, which is used for many things, especially in patients that have Alzheimer's for their memory. St. John's wort is used for mental health, such as depression. Ginger, very commonly used for nausea, but a lot of these are very commonly used. Most of these, in fact, have been around for decades, if not centuries or millennia, and they have a lot of evidence behind it. However, none of these are officially FDA-approved medications for any purpose. Let's go through a few different pharmacology principles. First of all, there's the term pharmacoeconomics. This means being considerate of costs in making a medication decision. For example, if I could give a patient a brand name drug, or I could give them the knockoff drug, if they're both literally the exact same thing, Tylenol versus the Equate acetaminophen are the exact same thing, but one's half the price, it would be a good pharmacoeconomic action to give the patient the cheaper medication. Another example would be if I can give the patient 2 pills for $4 a month, or I can combine it in 1 pill for $30 a month. Again, people would rather take less pills, but to save that $26, they may rather go ahead and just take an extra pill a day. Factors of absorption is what intrinsic and extrinsic factors are going to impact the delivery of the medication. So what are some examples? Well, if I give you a medication in your IV, but your blood pressure sucks, it's 60/40, that medication is not going to get circulated very well because your blood's not circulating very well, so it's not going to have a very good efficacy, or at least it's not going to have the standard efficacy, and that's where factors of absorption come into play. And there's a whole list of factors of absorption, which way I give the medication, whether I give it rectally, whether I give it orally, that's another factor of how well it's going to be absorbed. Obviously, the patient's overall blood flow status, and so much more. Another key thing to keep in mind is that the more doses per day that a patient needs to take, the lower their compliance. And that makes sense. If I need to do something once a day, it's relatively simple for me to remember once a day. If I need to remember it to do this constantly every 6 hours, 4 times a day, there's a much greater chance that some of these doses I'm going to forget and skip. So you are going to want to pay attention to what medications have that high frequency, and we almost always will cover any medication that needs to be taken more than twice daily, so that you know to make sure to give your patient extra education on that. Hey, you may want to set an alarm, or at least just confirm to them, hey, when you pick this prescription up, yes, it does need to be taken 4 times a day. Here's some tips and tricks for how to remember to do that. Remember NextGen testing for the NCLEX. It is not going to ask you which of the following medications needs to be taken 4 times a day. It's going to ask you which of the following medications would you want to educate your patient on the proper frequency of delivery, or something like that takes it a little bit more complicated, or which of the following patients would be most recommended to have an alarm set to take their medication. And if only one of those is taken 4 times a day and all the rest are taken once a day, that is your correct answer. Remember, for NextGen testing, be ready for that, because it's not going to be as simple, how many times per day is this taken? Sometimes we're going to have medications that are enteric-coated, or sustained release, or extended release. All of these things have one thing in common, specifically that they cannot be crushed. If a medication is enteric-coated, sustained release, or extended release, it is like that for a reason. By you grinding it up and putting it in the patient's applesauce or ice cream, you are messing with the way it's meant to be used. So do not do that. That being said, what do these terms mean? Enteric-coated means the capsule is coated to protect it from breaking down in the stomach. A classic example of that is aspirin. Aspirin is toxic to the actual stomach, to the GI tissues in the stomach. So for that reason, we often give it enteric-coated so that it doesn't start to break down until it gets past the stomach so that it doesn't hurt the stomach. Other times, medications can be enteric-coated for the opposite reason, because the stomach is toxic to the pill. So if the stomach's toxic to the pill, then we again enteric-coat it so that it doesn't start to break down until it gets further into the GI tract past the stomach. Other terms that we have here are extended release or sustained release. These medications are meant to be slowly digested over a period of time. So these medications, we're going to want to go ahead and make sure that we're not giving it crushed, because that would interfere with the proper absorption rate. Parameters are something that you're often going to see in your medication orders, and it affects your order. For example, a medication may say administered digoxin, X many milligrams, this route, this time, but withhold it if the patient's heart rate is less than 60. That is a parameter that alters the original order. So if you went and gave that medication, their heart rate turned out to be 45, you gave a medication you had no right to give. You did not have an order to give it because that order was invalid, being as the parameter was not excluded that medication. It could be the opposite. It could be, say, you can give this patient Tylenol only for a fever greater than 100.4. So if their fever is 100.1 and you gave that medicine, you essentially practice medicine without a license. You gave a medication you had no right to give because that order was not valid at the time you gave it. Always check your parameters prior to administering any medication. Remember, almost every med error is going to come down to the person that gave it. There may be others at fault as well, but if you as an RN gave a medication that was wrong, it's almost always going to be your fault. Remember back to your 6 rights of medication administration. Just like nurses have 6 rights when we give it, prescribers have the same thing. We have to make sure that an order is properly written, it's properly valid. You need to verify that. What makes it valid? What makes it valid is if the medication order has the drug name, the drug dose, the drug route, and the drug time. If it's missing any of those, it is not a valid order. Even if the medication doesn't come in any other route, if it only comes PO and it doesn't say PO, that is not a valid order. You need to get the provider or understanding orders. Maybe you'll be allowed to do this, but you have to get that filled in or else the order is not valid. A few best practices that we have when it comes to pharmacology. First of all, do not ever refer to medication as candy to get a child to take it, because yes, that might work for today, but that's also going to work 3 weeks from today when he sees his grandpa's medication and he starts to take that because that great nurse told me it's candy. Do not mix medication with juice or milk to get the child to take it. You can do that with other things like soda, but don't do it with the healthy drinks like juices or milk. And this is fair game for a test, even on the NCLEX, because it is standard practice that we don't want to mix our medications with juice, milk, or healthy substances, because that might alter the taste of it, and especially in children, that might make them never like that again. And that's fine for soda. That's not the greatest for them anyway, so it's okay if it gets them to not like that. But things like juice or milk, that would be a pretty big deal. Remember, the most common healthcare error in all of healthcare is medication errors. The numbers we have are staggering, even with EMRs and triple checks and the extensive training that our nurses and our providers have. These still happen. So you have to make sure to always be cognizant of that. Again, remember, it's usually going to come down to your fault if you're the one that gave it. Medications that require your vital signs to be assessed should be assessed at the time you are giving it. If you're doing your 9 o'clock med rounds and you're supposed to check the patient's blood pressure before giving the medication, writing down your 6:45 a.m. vitals is wrong. You have to take your vitals at the time that you gave it, because the vitals could absolutely have changed, and now maybe the medication is not supposed to be given to that patient anymore for whatever reason. Also keep in mind, and this is 100% something you're going to hear from me over and over again, especially for those of you getting ready to take the NCLEX. NextGen testing is very insistent upon you understanding that every single medication that you give, you're going to assess the patient beforehand, you're going to assess the patient afterwards, but not only that, you're going to assess whatever it is that you're treating. So you probably already know, if I'm giving you a blood pressure medication, I'm going to assess your blood pressure before and I'm going to assess it after. But it's not only blood pressure. If I'm giving you a medication for your thyroid, I'm going to assess the signs and symptoms of hypo or hyperthyroid, and I'm going to assess it afterwards. If I'm giving you medication for your depression, I'm going to document something about your assessment before I gave you your Zoloft and again after. Keep in mind, you must be familiar with every single drug you give to know what it is treating and to understand what you need to assess and what you need to reassess, because every medication is considered an intervention, and every intervention requires an assessment and a reassessment. Next, we're going to talk about non-pharmacological interventions. Non-pharm interventions are very frequently used, and we're going to talk about it for so many things, everything from hypertension to depression to insomnia to pain. But you do need to understand these, especially when it comes to pain. Understand that if I'm giving you morphine, that doesn't mean that the non-pharm interventions go out the window. I should still see, hey, can I make you a little bit more comfortable in bed? Can I turn the TV on to distract you from your pain? Just because I'm giving you a drug for it doesn't mean I get to neglect the non-pharm interventions, especially when it comes to things like high blood pressure. Oh, well, I'm on medication for it. I don't need a diet and exercise. Yes, you do. Next, most IV medications are packaged in one vial, one dose, thankfully, and that makes our life a whole lot easier. Except, as we mentioned earlier, there are those exceptions, the multi-dose vials, and you have to be cautious of those because those are definitely not one dose, one vial. Most of the time, that is the case. The big thing to keep in mind, if you go to the Pyxis or wherever your drugs are stored and you're having to grab 16 vials to give that one dose, please check what you're doing because you're doing something wrong. That is extremely, extremely rare. I can think of maybe one instance where you'd be grabbing a whole bunch of vials for a single dose. That rarely happens. So double check what you're doing. One dose is the standard, or one vial, maybe a second, but it shouldn't be more. Always ensure proper patient education. You must educate your patient on every single drug that you give them. When you give them a drug, you need to educate them on what are the signs and symptoms to look out for, at least the common ones. You don't need to tell them headache, nausea, whatever. Every drug can potentially do that. But you should tell them the common ones or the way out of left field ones. For example, rifampin is going to turn their tears and their urine red. That's probably a good idea to educate them so that they don't freak out the first time that happens after the first dose and come running to the ER. Oh my God, I'm peeing blood. No, you're not. It just turned your urine a little orange red, but you're otherwise fine. So you have to educate your patient on this. Plus, keep in mind the most important thing of all of that is that when you educate your patients on why they need to take this medication, it is dramatically going to increase the chances of them properly taking it. I can tell a patient all day long that they have high blood pressure and they need to take this medication. They feel fine. Well, of course they felt fine because the blood pressure came up. It took 20 years for them to become hypertensive. The body adjusted. They have no symptoms. They feel fine. But we know that their blood pressure is high and needs to be treated, but they don't. It is our job as nurses, as nurse practitioners, to educate our patients to make sure they understand why they're taking that medication so that they are part of our healthcare team and part of our plan to get them better. And finally, always assess your patient after any change in their status. Real quick, let's go through controlled substances. You probably know a little bit about this already, but let's go through it. This is a list kept by the DEA of drugs that are high risk for abuse and dependency, and that's all it is. Just because a drug is on here doesn't mean it's a narcotic, doesn't mean it's a benzo, doesn't mean anything else. It just means it has a high risk for abuse and dependency. These are divided into 5 classes, Schedule 1, 2, 3, 4, 5. Schedule 1 and 2 are both equally the highest level of risk for addiction and dependency. The only difference between 1 and 2 is 1, those drugs are considered 100% illegal with no legitimate purposes, and 2 are considered just as addictive, but those drugs do have legitimate medical purposes. Do keep in mind that at least as the time of this recording in mid-2023, marijuana is considered a Schedule 1, the highest level of addiction with no legitimate medical purposes. However, we know that at many state levels, this medication is approved and legal. That's Schedule 1 and Schedule 2. Schedule 3, now we have a step down in how addictive a medication is considered. Schedule 4 and 5, we keep moving down the list. Most of our benzos are going to be on a Schedule 4 because they're a relatively low risk of abuse and dependency, especially compared to something like morphine or fentanyl. Schedule 5 is going to have some other things. Like I said, keep in mind there are some drugs on this list, such as testosterone, such as some sleeping pills that have nothing to do with narcotics that are there because they have that risk of abuse and dependency. Next, finally, I want to talk about pregnancy real quick and we'll wrap it up. The FDA for many, many years used pregnancy category labels on every single drug, A, B, C, D, and X, X being a no-go, A through D being A, the most safest, D being unsafe. You may still see this on your textbooks. You will not see this on any board licensing exam. You won't see it on NCLEX. You won't see it on your nurse practitioner boards. Now we look at every single medication, we review the data, and we say, is this safe or is this not? There's no just label that we put on it. It's a B, it's good. It's a D, it's no good. We make a decision based on the risk versus reward. I do want to go over one medical terminology here, and that's teratogenicity, and that is how toxic a drug is to a pregnancy. A drug that is teratogenic is toxic to a pregnancy, and there is a term, highly teratogenic, such as valproic acid, which means that even of the drugs that are not safe in pregnancy, this one is even above and beyond worse. There are some drugs that will be told that they're slightly teratogenic, and that's where the provider and the patient have to have a discussion. Is it better to take the risk with the medication, or is it better to take the risk to go off your medication and your condition, whatever it is, goes way out of whack during your pregnancy? Thank you so much for watching. Have a wonderful day.